Good afternoon, everyone, and I cordially welcome you all to the 95th session of eNischit. As you all know, eNischit is a platform, is an endeavor for capacity building in field of TB, HIV, and we all are making sincere efforts in doing that. So I welcome you all. And I'm Dr. Ananya, Prabhu, chest specialist at National Institute of TB and Respiratory Diseases. And here's our team of eNischit. We have Dr. Jyoti Sharma on my left, Vikas Gupta, who is the head of Neurosurgery and Neurointerventional Surgery at Kailash Deepak Hospital, Karkardooma, Delhi. And sir, then we are very fortunate to have you on board, sir. Thank you for joining us, sir, today.
You.
Yes.
And thank you to give me all this opportunity. I hope it is fruitful for all.
Yes, sir. We're all looking forward to your guidance. So today we are going to touch upon a very important topic which has been shared to us by Dr. Devanand, Cuddalore IIRT Center, Tamilnadu, which talks about the CNS lesions or the CNS nervous neural issue in the HIV patient. So we all know that as the longevity of ART patient, HIV patients have increased. So these neural problems have become common. We see them commonly in our centers, and they could be because of multiple factors. It could be primarily HIV neural problem. It could be opportunistic infections. It could be a comorbidity, or sometimes the side effects of the ART that the patient is taking. And sometimes it's just confounding illness, coexisting illness such as impaired glucose tolerance, which gives you peripheral neuropathy kind of symptom, or alcoholism. So it is very baffling, and we are very glad that somebody has given us a case like this so that we can get the right perspective from our expert today. So this is very good that we have this neural case of HIV today. So now I would like to start the agenda with the case presentation. So I would invite Dr. Devanand to please present the case for today.
Good afternoon, everyone. I thank everyone on this forum, and let me proceed with my case presentation. Am I audible, please?
Yes.
Yes, ma'am. 63-year-old female was admitted in the month of April with complaints of weakness of left upper and lower limb, weight loss for the past 1 month, and deviation of left angle of mouth and slurring of speech for the past 1 week duration, and involuntary bowel and bladder movements 4 days duration, blurring of vision and headache 2 days duration, in that order. So the presenting illness, initially she had difficulty in wearing slippers and later progressed to difficulty in lifting hand above and difficulty in climbing stairs. Slurring of speech past 1 week, involuntary movements and blurring of vision, headache for the past 2 days duration was in that order she was admitted. From the past history, she's a known PLHIV since 2001, not a known diabetic or hypertensive. She had a cataract operated 2.5 years ago, hysterectomy done for CA uterus in 2001. Radiation was not done as she was not willing. And regarding the drug history, she was on ARV drugs since 2002 privately. The details are not known. She registered in the government setup in the year 2006, started with the SLN, switched to ZLN in the month of May 2012, and then to TLD regimen in October 2021. Had maintained greater than 95% adherence since 2006, as indicated by her serials of CD4 counts and viral loads. The following investigations was done. MRI brain with contrast showed well-defined peripheral enhancing altered signal intensity mass measuring 5.3 into 3.5 into 4.2 centimeters in the right high lobe, frontal lobe. CSF and sputum analysis with the cartridge-based nucleic acid amplification test was negative for TB. CSF adenosine deaminase was elevated. Later, she was started on ATT. Serum toxoplasma Ig was reactive. And unfortunately, she died of aspiration pneumonia in June 22. Following that investigation, treatment was started. She was started with injection dexamethasone and tablet brivaracetam and combination of trimethoprim, sulfamethoxazole double strength, and ART was continued. With little improvement, she was discharged after 5 days. And in spite of all these good immunological and virological status, so my aim was to discuss about the presenting case as a hemiparesis with all immunological and virological status. That's it, ma'am.
Thank you, Dr. Devanandji. It's a well presented and well worked up case. So while everybody is attempting, I'll try to just recapitulate the case. So it is it's a case of a 64-year-old female who had started on IRT in 2006 from private, and then later on she was registered in government also. She was started on IRT in 2002, and then from government she was registered in 2006. And so she had presented to us with complaints of weakness of left upper, and presented to the ART center with the weakness of left upper and lower limbs, headache, blurring vision, March 2022. And there was no history of morbid diseases like diabetes and hypertension. And patient, when they evaluated they found that patient was on a good ART adherence, more than 95%. Initially, she was in SLN, then Zidovudin LN, and then she was switched to TLD in October 2021. And she had always maintained a good adherence. So she was admitted with those complaints, and when she was evaluated and investigations were done regarding that, so CBNAT, they thought maybe in suspicion of tuberculosis, CBNAT was done, and it was negative. The MTB was not detected. ADA and CSF was high. So in view of, I think, clinical and ADA picture, the ATT was started. MRI brain with contrast was done, which showed well-defined peripheral enhancing altered signal intensity mass, measuring 5.3 into 3.5 into 4.2 centimeter in the right high frontal lobe. So there was just one big mass. And other significant investigation was that toxoplasm IgG was reactive. Patient was not willing for any other investigation, especially for, as they said, ruling out glioma. Other investigations were not done. So basically, it's a very good case, and because the symptoms they can lead to of hemiparesis, and they can lead to diagnosis of tuberculoma or toxoplasma. So there was a confusion. And that's why they took up this case. But like usually in tuberculomas, we get these firm avascular spherical masses varying from 2 to 10 centimeters. So sitting at ART center, you can be confused whether this is what this mass looks like. That's why we are glad that today we'll be enlightened on the radiological aspects and other aspects of how to approach these neurological diseases. And also that toxoplasm IgG was reactive. So one thing I would like to add on it was like usually we get seropositivity toxoplasm in HIV patients, especially if the CD4 count is low. But it's like for actual toxoplasm, cerebral toxoplasmosis to happen, there has to be more collaborative evidences also. So and they are also hyperdense lesion with some eccentric markers. These hyperdense lesions. So basically, it usually happens when CD4 count is very low, more or less than 200. Clinically speaking, we just speak at what we see at ART. Less than 200, less than 100, we see these opportunistic infections happening, because when your CD4 counts go down, then there's cytokinins and then gamma and front dysfunction, and that leads to activation of latent infections. So indeed, it is a very, very interesting case, because it is baffling when you just see a mass and you're not too sure of you don't have any microbiological or definite diagnosis. So how to approach the patient and what to do with the patient. So I will be inviting the expert for the dietetic.
So good afternoon to all of you again. So this is the case to recapitulate. 64 years old lady. Only thing I would like to emphasize, in addition to what has been said, there's a very significant history of hysterectomy in August 2021 for hysterectomy. Just keep this thing in mind. The history mentioned that the stroke-like symptoms leading to diagnosis of tuberculoma, toxoplasmosis, glioblastoma of the right frontal lobe. No bleeding pathology. So initially, I did not have access to the imaging. I got access to the imaging a couple of days ago, so I've added them. So it shows a well-defined peripheral enhancing mass on contrast MRI with usual mass effects, effacement of the lateral ventricle. And MRS showed reduced Na, increased choline peak, which in normal population would mean something like a glioma. These are again the images. So as a HIV case, there are numerous possibilities. Just to be useful, instead of saying yes or no, let us visit some other neurological manifestations of HIV. It will be helpful for me and for you to put the things in perspective. It will take about 20-25 minutes. I hope that is fine.
Absolutely, sir.
So, neurological involvement in HIV. It is not as rare as we think, at least practitioners think, people outside the HIV clinics think. Almost 40% to 60% of the patients living with HIV or AIDS will develop neurological disorders. And even 10% of the people will develop intracerebral masses. And believe me, for the people who are not in HIV field per se, it is almost a question out of syllabus. It bowls us out of boundary. Anyway, the most common is receptic meningitis. It occurs in about 25% of the infected individuals. The most common is unexplained facial asymmetries, which are basically nerve palsies, unexplained arm or leg pains, which is radiculopathies, and some kind of acute demyelinating polyneuropathy. Suddenly you find the person is not able to lift his hand, move his fingers, some kind of a limping. That is a polyneuropathy, which should revert by itself. And usually manifests 2 to 6 weeks after the infection, and may be the primary reason that the individual seeks medical attention for HIV after HIV infection, which leads to detection of HIV. So just keep in mind that acute retroviral syndrome is the most common. And if we happen to image these, surprisingly, this is an image of this is my image from my collection of the patients. This is a young lady, just 23 years old. It is not my primary practice to be in HIV, but still I keep collecting these images. So this looks like a image of a senile person of 70 years plus or something like that. That the sulci gyri are prominent, the ventricles are prominent, the brain substances thinned out. And volume loss on axial flare image is profound. This is just 20 years old woman. And other, in addition to the volume loss, you see some specky signal abnormalities in white matter, which in isolation could represent typical HIV-associated encephalopathy. So you need a trained eye to keep an eye for these kind of people who come with disorientation or vague symptoms to make a diagnosis of acute retroviral symptoms. And in addition to that, just to complete the discussion, they come with dementia. Young people come with, is there any questions? I'm seeing the raised hands. I'll request you to interrupt me whenever you feel like.
Please ask the question on the chat box so that we can forward it to sir.
Dementia is one of the early features, one of the most common features which we see on clinical practice. So you see a young male or woman studying in a university or whatever he's doing, he comes with certain forgetfulness or unusual features. On investigations, you may find something or on the imaging or not, but dementia remains a very suspicious cause of HIV, suspicious symptom of HIV, which leads to the diagnosis of HIV. Approximately 50% of the HIV seropositive patients are thought to be having some cognitive impairment. Now, in the era of widespread use of ART, severe form of HIV-associated dementia become rarer, while the prevalence of milder forms using asymptomatic neurocognitive involvement of minor has remained unchanged. The presentation, as you may think, that the cognitive function of the human being is vast, so the changes are in manifestations are vastly different. They cannot be put into straight bracketed definitions. Again, just to complete the discussion, the neurocognitive disorders is characterized by gradual decline in cognitive functioning, something the person is trained into, something the person is well read into, somebody loves the music, somebody loves the reading, somebody has good in mathematics. Suddenly they start losing interest and they're unable to do those simple calculations. This may be occurring long after initial infections, and the clinicians has to be really alert to pick up these things, because unfortunately we do not have too many trained uh, occupational therapists or the people who can run battery of tests to recognize the cognitive decline or occupational decline. But this is one of the very prominent symptoms, which I'm putting into the perspective that the radiology may or may not be helpful. Motor slowing is usually evident, sometimes coincident, but with often after the onset of cognitive decline. Both are progressive, and behavioral changes may also become apparent. Coming to this CSF evaluation, we always used to think that once you do, as the somebody mentioned, that the lady was not willing for any invasive investigations. Even if the invasive CSF was done, there's a very little clue which the CSF gives us. Mild lymphocytic pleocytosis is the elevation of protein levels. If you just dwell on this for a minute or so, this mild lymphocytic pleocytosis is something which is very common in our country. This is something which is commonly seen with the mild tubercular infections, which majority of people are exposed in India without having clinical tuberculosis as such. Only the CSF finding with the focal lesions on imaging or more extreme findings in CSF evaluation should prompt evaluation for other or coexisting illnesses. Some of the radiological findings may be manifest in reversible causes such as medical derangements. These people have certain kind of medical derangements, mainly in terms of hypoglycemia and other things. Now, coming to the relevant discussion, what this MR revealed to us is something like a mass with a peripheral enhancement. You'll be amazed to know that the majority of the HIV patients, they may reveal tumor-like single or multiple lesions, which are called tumor-effective demyelinations. They are not actually tumors, they are called demyelinations. They should be strongly considered in the differential diagnosis of infections. Whether on this was glam or not, I'll come to that. But I am completing the discussion so that we have an idea once we again look at the patient of intracerebral mass in the setting of HIV. Characteristically, these lesions may have open ring configurations, C-shape enhancement on post-contrast imaging, which is frequently seen in tumor-effective demyelination. Keep this thing in mind. This will be very helpful in clinical presentations and discussion, and of course, management of the patients. As such, as I said, this our case under discussion was already diagnosed, but sometimes brain tumors or this kind of tumor infection myelination may precipitate the diagnosis of HIV. So look, this is a stock image. The man presented with the left-sided weakness. This is same contrast enhancement, but of course incomplete. Our patient had a complete. This is MR, contrast MR, again an MR. This is a PET CT. FDG uptake along the lesion. This patient incidentally underwent a stereotactic biopsy. This is an old patient of mine. Revealed a macrophage lesion compatible demyelination. He responded only to HIV medicines or ART, whatever it is, but he responded completely well. The weakness reversed. So keep this image in mind, compare it to the image with the other person concerned for the today's case discussion. So unfortunately, our patient did not get the biopsy done, but this image and the clinical presentation could have been identical. So this could be relevant. Biopsy is conclusive. Tumor effective. Just keep it. This is a tumor-like demyelination. Responds well to corticosteroid therapy. ART would need to be initiated at some time if the diagnosis of HIV is concurrently discovered. Although tumor-effective demyelination is a distinct entity that occurs in patients with HIV and is generally monophasic, rarely this can be the very first presentation of what may later manifest as multiple sclerosis. So this is slightly more technical, but what I'm trying to say is that simple corticosteroid would have made this tumor to disappear. So there's no need of a craniotomy. So this is a stereotactic biopsy. If you look at this, this is a tumor. and we make it just small hole with the help of a stereotactic frame, and it can be done under local anesthesia and fairly well, good yield of more than 95%. This is something which CD8 encephalitis, which was added to the HIV CNS complication in 2018, occurs in the virological controlled individuals on ART, may be precipitated by recent viral infections such as URI. Biopsy is frequently required for the diagnosis. DD includes glial tumors, lymphoma, and tumor infection demyelination. And these are the radiological findings. I'll just keep correlating clinical picture with the radiological findings. So in contrast to tumor infection demyelination, these are bilateral, diffuse, in the gray matter and the white matter. And this is CD8 plus encephalitis lesion mimicking tumors have been described. These are very difficult to prove unless biopsy is obtained. Increased risk factors for stroke. Somebody mentioned Dr. Devanand, I believe, that while introducing the case, he said the features of a stroke. Yes, HIV has an increased incidence of stroke as compared to the traditional population. In addition to the hypertension and hyperlipidemia, because of the ART and the disease per se, there's increased risk of hypercoagulability manifested by the presence of antiphospholipid antibodies, elevated of tissue type plasminogen activator antigen, and elevated level of plasminogen activator inhibitor and protein S deficiency in HIV positive patients. They can have a more predilection for stroke. We have been treating them for stroke. Acute strokes have been found to be occurring more in HIV positive patients, but yes, by and large controlled due to the ART. HIV been considered with vasculitis and endocarditis, rare in children, but yes, children coming with stroke, HIV is a strong possibility. Of course, there's no compelling evidence to strong association between ART and increased incidence of stroke, but we see the metabolic spectrum is altered, so that is why we believe that this is possible. Stroke must be considered in the differential diagnosis of HIV positive individual with an abrupt onset of neurological symptoms. Now coming to infections, Toxoplasma gondii and fungus cryptococcus neoformans. You must be more familiar with them more than I am. I am a surgeon. I am not concerned with too many infections as such, but yes, I included them just to complete the neurological constellation of HIV. Otherwise, they are very difficult to differentiate from one from the other. Human exposure occurs through the contact with oocytes shed by its definitive host, the cat. The risk of AIDS-related CNS toxoplasmosis has been related to the prevalence of toxoplasma exposure on a particular population or area. After infection, persistent or asymptomatic cysts form in both brain and muscle. The activation occurs as a consequence of impaired cellular immunity, as is the normal in any kind of a infection, and causes encephalitis, multiple lesions. This is the picture of toxoplasmosis. They can also mimic something like a tumor to a untrained eye or without the suspicion of HIV. Nodular ring enhancing lesions, surrounding edema, this could be tuberculoma, this could be neurocysticercosis, this could be toxoplasmosis, this could be glial lesions. So HIV actually is a confounding factor in all these kind of illnesses. Fungal infections, again, I'm not the master of fungal, but still, again, to complete, organism is found in bird excrements, infects human via inhalation, although overt pulmonary infection and pneumonia are rare. In the setting of HIV infection, both meningoencephalitis and isolated encephalitis may occur. Again, reactivation of the latent infection. The cryptococcal meningitis develop over a period of weeks to months. Immune response is impaired and finding may be more subtle, and cranial neuropathies are more common. People come with facial asymmetries, inability to swallow, inability to see straight. The cranial nerves and the eyes may be impaired. Hydrocephalus is common, and post-hydrocephalus there may be strokes. I'll come to the hydrocephalus and strokes. Direct involvement of the brain parenchyma when present may lead to focal or diffuse, and symptom and sign may be vary according to the area or areas affected. That is basic neurology. So this is cryptococcus. Again, on a single MRI image or a couple of MRI images, you cannot make out whether it is single ring enhancing lesion is tuberculoma or toxoplasmosis or cryptococcus, but this is a biopsy proven cases, a few cases which I have shared with you. So this is showing already some ventriculomegaly. So if the cryptococcus or any kind of encephalitis is affecting the base of the brain, what is called basal vasculature, that leads to meningitis. And once the basal substrate of the brain is involved, that leads to exudates in the base of the brain. That leads to impaired absorption of the CSF, hence the hydrocephalus. Most commonly, obstructive hydrocephalus is known for tuberculosis, right? But in all these kind of infections, cryptococcus or toxoplasmosis, wherever there's a systemic infection or inflammatory infection or the bacterial or fungal infection of the brain, in case the basal substrate is involved, that can lead to obstructive hydrocephalus. Mycobacterium tuberculosis, which to my perception, again, as I said, I never worked in a predominantly HIV facility, but whatever it comes across in our clinical practice, the Mycobacterium tuberculosis is one of the highest ones. Patients with HIV/AIDS are particularly prone to reactivation of tuberculosis and to extrapulmonary infections. In case of CNS involvement, many infected patients have a history of pulmonary tuberculosis. The atypical bacteria, Mycobacteria avium and the Mycobacterial intercellular, are endemic in the environment, found in water cell and you physicians, you know better than all this than me. What is important is that these kind of meningitis, tubercular meningitis or other fungal meningitis, these we are dealing with immunocompromised patients. So you may not find typical neck stiffness, you may not find typical high-grade fevers. They come with advanced symptoms like maybe strokes, maybe hydrocephalus, maybe headache, maybe vomiting. And the imaging may lead us to lesions, which we may find like fibrotic tuberculomas, tubercular abscesses. So this is again a ring enhancing lesion. Very difficult to differentiate one from the other, but a ring enhancing lesion should give rise to the possibility of, we should look at the immunosuppression as such, and any of these infections can be possible. The first next thing would be a CSF and histiotechnic biopsy. This is a target lesion, which is possibly a precursor of a tubercular abscess. What is the difference between tuberculoma and abscess? Abscess is usually solitary and much larger than a tuberculoma. Tuberculoma is a completed immune response. Somehow the body or the brain has walled off the infection. Whereas a multiloculated that keeps growing and it has a mass effect, have elevated lipid and lactate peaks on the MRS. And they're significantly larger and as compared to tuberculoma. Obstructive hydrocephalus may be a medical emergency. Patient may come to the ER room. He may need a ventricular drain or a shunt, or sometimes a third ventriculostomy. Brain abscesses, however, frequently need, and this is a typical patient of a pulmonary tuberculosis presenting with obstructive hydrocephalus. If you look at the base of the brain, they are basically exudates leading to hydrocephalus. This is the temporal horns which are dilated, the frontal horns which are massively dilated, and the cortical mantle is reduced. This is how the basal brain, you can see the exudates. There's a fulminant exudates at the base of the brain. And this is the ventricle which are dilated. So this patient will need a shunt. VP shunt is, the hole is made in the skull and the hole is made in the peritoneum. The shunt diverts the CSF from raised pressure, which is a valve here. If you can, I don't know whether I can make you discrete. This is a valve. And the valve will arrange that the fluid is thrown into the peritoneum according to the pressure. Now coming to the CNS lymphomas. These are, you'll be surprised to know that the names which are taken even in this MR report, this is written gliomas, lymphomas, we've come across but they are very rare in the presence of HIV. Account for fewer than 5% of the primary CNS tumors. The emergence of AIDS epidemic was mirrored by a rise in the season incidence and soon becomes AIDS defining illness. Maybe 20 years ago when we were students, HIV patient coming to a neurological hospital like Jeevan used to mean that we are dealing with some kind of a lymphoma. Yes. Lymphomas are per se periventricular lesions. Lymphomas do not obey the boundaries of the lobes. They can transcend into lobes, as you can see, they can transcend into right, into left. And this is typically involving the corpus callosum. This is taking the shape of splenium of the corpus callosum. Fortunately, with the advent of effective ART, it has become less common. 2% of the HIV infected individuals in the developed world PCNL will be diagnosed in their lifetime, but autopsy series may put the incidence at 10%. As I showed you, that occupies the white matter spaces like we show corpus callosum, may range from non-specific, non-localizing headache, mild encephalopathy and delirium to those associated with discrete lesions called low contact. Now, primary CNS lymphoma is second only to cerebral toxoplasmosis as a cause of space occupying CNS disease in the developed world, and needs to be considered in any HIV infected patients with either a single or multiple contrast enhancing lesions. These are our guidelines, which is 2018, which say that the lymphoma is second only to toxoplasmosis as a cause of space occupying lesion in the CNS disease in the developed world. Biopsy again is indicated, which was not done in our patient. Biopsy can be misleading because patients have received corticosteroids before biopsy because these drugs are acutely lympholytic and mainly transiently obscure the diagnosis. I must emphasize a point, there's a limited role for craniotomy because majority of these diseases are amenable to diagnostic biopsy, and definitive surgery in presence of proven HIV probably doesn't have much of a role, at least not to my knowledge. But biopsy in these patients is also slightly risky. Infection, bleeding, and death are increased. Biopsy per se is a very, very simple, straightforward procedure, but in presence of immunocompromise, there may be other issues like heart or chest, which may increase the statistical risk of complication. Another interesting finding is Kaposi sarcoma and leiomyosarcoma. I have come across one patient whose imaging I have kept. This is the parotid glands. You may see the cysts in the parotid glands. The findings are always in the base of the brain. This is the base of the brain. This is the mandible area or jaw area. So you see multiple cysts. The multiple cysts you can see in the parotids and the submandibular glands. When they present with multiple cranial palsy, the patient is actually very pathetic. He cannot close the eyes. He cannot control his saliva. He cannot see it left and right. So this is a lymphoepithelial lesion. Now, coming to viral infections, JC virus can spread by B lymphocyte into the CNS. Demyelination follows, and this is what is picked up on imaging. Multiple areas of enhancement, multifocal, asymmetrical distribution, edema, massive edema, contrast enhancement, all those rare, there's a less atrophy. Now, coming back to our case. I have covered from infections to tuberculoma to toxoplasmosis to lymphomas. So this is our case. You'll be surprised to know that the gliomas are the most common primary CNS tumors. But as per the literature, they are rare in patients living with AIDS. They are difficult to diagnose because it shows unusual aspect of tumor localization and growth behavior. They manifest as other mass effect, as in our patient. Probably they affect at younger age in HIV infected population. Maybe if the biphasic age comes at about 60 to 70 years, they may come at 10 years earlier. But the incidence of glial central nervous tumors is 0.05%. Where other focal masses, which I discussed, that is why I took the trouble of discussing every other mass before coming to the glial tumor, is up to 6%. Otherwise, treatment is same as any other patient. There's no evidence to suggest this patient should be treated differently. That is, after a stereotactic biopsy, they should be subjected to craniotomy followed by radiotherapy and chemotherapy. Median survival time is almost the same. So, in my opinion, this patient should be treated as, since we don't have a biopsy, I have a strong suspicion that he had a adenocarcinoma surgery just a year before. So this should be called a metastasis rather than anything else. I would put it as a case of metastasis, or will be very reluctant to put a diagnosis of glioma per se. Thank you. If there are any questions, I'll take them.
Thank you, sir. Thank you for the excellent presentation, sir. I would like to ask Dr. Devanand if his doubts are cleared and he would like to ask some questions. Also, other ART centers, please, you can. It's open for our discussion now.
Yes, madam. I have few doubts. Sir, good evening, sir.
Good evening.
Sir, but here our most important thing was, in spite of all good adherence and viral load CD4 test with no immunological compromise, can this metastasis present as such? Can it be, as you said, she was previously treated for carcinoma of uterus? It can be a metastasis as radiation was not done. But can the metastasis lesion be so huge, sir?
Yes, yes, of course. Of course. Peripheral enhancing lesion. I would keep my bets around metastasis, because the principle of neurology, or for that matter medicine, is that there should be one pathology instead of putting your eggs in too many things. If she is controlled, well controlled on HIV, ART, other things, so once you have found a carcinoma, that should be considered as a possibility of causing the metastasis. Yes.
Yes, sir, but every symptoms and signs happened within a month duration.
Yes, adenocarcinomas, they give rise to metastasis very fast. Yes. There's no rate of growth of these adenocarcinomas.
Right, sir. Thank you very much, sir.
Right. Yes.
Sir, I would like to ask, how practical is biopsy? Because in HIV scenario, they are always so comorbid, and constitutionally they don't look like the candidates who can undergo biopsy. So practical.
Yeah, I know that neurology per se in the medicine class used to be very boring, and that seems to be the case here also. Anyway, for your information, it should be useful for everybody that normally these stereotactic biopsies are done under local.
Okay, sir.
Any good medical college, which I believe in the periphery, should have a stereotactic biopsy facility, and it generally does not add to the complications. Generally doesn't add to the complications. It's a fairly straightforward, simple procedure, and a very good diagnostic yield. I would strongly encourage that instead of living with this kind of questions that the patient died, what are we dealing with? It will be good in the interest of everybody that a good biopsy should be obtained. At least I don't see any contraindication for a biopsy. I have included that the increased risk of complications, but that is compared to the normal population. These people always have some higher risk, which the literature agrees. That is why I had to put the slide on. But otherwise, biopsy is a fairly straightforward procedure, which is done a half-an-hour job in the local. These things are, I think they should be available everywhere. I don't think there's a challenge there.
Thank you, sir. One doubt I would like to ask, generally we have known that CD4 cells also get low in gliomas and glioblastoma. So the high CD4 that was maintained, does that also go towards a pointer towards maybe it was a metastasis only?
Maybe. That will remain a suspicion. We don't have an answer because we don't have a biopsy. Maybe, yes.
Okay, sir. Okay, sir.
So thank you, all of you.
Thank you, sir.
It is really grateful to see 227 people plus. I hope I may have added to something to the knowledge, maybe.
Yes, sir. Thank you.
I learned a lot that the gliomas are rare in HIV. We used to know it, but going through the literature was a lesson for me also. Thank you. Thank you all.
Thank you, sir, for your guidance.
Thank you, sir. Thanks so much. We are come to a closing of session, and please attempt the feedback poll as well. And any questions, please text us.
The link for the post-test and the feedback will be on even after closing the session. So I request all the participants to please attempt the post-poll and the feedback also. Thank you so very much to attend the session. Thank you. And I thank Dr. Ananya
Yeah, thank
to
you.
moderate the session. Thank you, ma'am.
Thank you. Pleasure.